So Dawn Saffayeh is the Deputy Commissioner of Policy Planning and Measurement at ACS. When I reflected on that title, I was trying to think, well, what's left out of that? Isn't that everything we do at ACS? But has really brought several advances to ACS in our practice there. One of them is the development of more results-oriented focus in practices offered to adolescents. We all have, for many years, have struggled to find the best ways to engage and work with adolescents toward a better path. And she's really committed to finding more programs and more ways to do that work with a results orientation. Along with her expertise, she's another very common sense partner for us as we look at these practices and move forward. So Dawn, thank you for coming, and tell us why funders are looking at evidence-based practice.
Thank you, Bill. I'm really happy to be here this morning. As some of you may know, ACS is really moving towards making some large investments in evidence-based practice. And so I'm here to talk about why we're doing that. We've had some critics tell us we're moving too fast, we're doing too much. And so I want to share with you the rationale for why we're doing it. I'm going to spend about 10 minutes talking, I think, and then we're going to open it up to questions and comments, because I really am interested in hearing your thoughts as practitioners about these programs and about our direction. So I don't really need to give you our definition, because Dr. Butts went through and talked about what an evidence-based program is, but ACS, we have our own definition, which is there. Our goal is to provide services to children, youth, and families that will yield the greatest promise of results. And as Dr. Butts talked about, there has been quite a bit of advancement in the field of juvenile justice in developing evidence to show reduced recidivism. And in 2006, ACS launched the Juvenile Justice Initiative, where we procured MST and FFT services to divert youth from placement. And I'm going to show you a little bit of data on those programs, but we think that the results are very promising. Our strategic plan, which we are now implementing since last year, really focuses on bringing those types of models to our preventive and foster care programs. And our goals for that is, well, so very concretely, we are procuring services for 3,000 teenagers that come to the attention of the Division of Child Protection. We've heard from our staff on the front lines that are doing investigations that there are very few programs to serve teenagers, and why are there programs for PINs and juvenile justice youth, but there aren't programs for youth that are coming to ACS through the Child Protective door. So that solicitation is active. We also are offering all of our general preventive programs to convert to an evidence-based program, and we have another active solicitation that lists 6 or 7 different models that all have a base of evidence. Most of them are the Check Plus from what Dr. Butts spoke about, but we also are allowing providers to propose a promising practice as long as there is a manual and that there's going to be fidelity monitoring. So we're moving in that direction there. And then in foster care, it's very interesting because we learn so much in juvenile justice, and there's a lot of evidence-based preventive programs out there, and we have been looking at our outcomes for foster care, and they are really across the board, across providers. Some providers do really well in foster parent support, others do okay in adoption, nobody does really great in adoption. And so we talk to different academics, researchers, program model developers across the country to see if there was an evidence-based program for foster care to improve the outcomes that I've listed here: expedite permanency, improve stability, and reduce reentry. And the answer to that question was no. There's no model out there that is prescriptive, and there's a developer monitoring fidelity. The only thing that came close was the multidimensional treatment foster care model, which was developed to serve juvenile delinquents that need out-at-home placement but not residential. So we are piecing together different components of evidence-based practice that exist to support birth parent engagement, foster parent support, and then putting other prescriptive measures around caseloads and qualifications together and testing a new model. It's called Child Success NYC, with 20% of the children in regular foster care, and so we're really hopeful. It will not end up being an evidence-based model because we're not using experimental design, because it wasn't really feasible or we didn't want to do that in New York City, but we're really hopeful about the results, and Chapin Hall is evaluating that program for us. So why invest in evidence-based? I've listed 4 reasons here. I think there are probably more. The first is very obvious, a focus on outcomes. When we look at the outcomes that we're achieving as a system in New York City and we compare them to some of the federal measures, we see that there's certainly room to improve. One thing that, I'll show you is our repeat maltreatment data, and we have a process within ACS looking at our child protective cases weekly, and every other week there's a case with 3 or 4 prior reports, and so a major concern about families that are cycling through our system and are not getting the help they need, and so really trying to figure out how we can strengthen our service models to improve outcomes across the board in child welfare and continue that work in juvenile justice. The models are better tailored to family needs. I'm going to talk more about that, but are looking at the models really, they're much more family friendly than the traditional preventive and foster care models that we've contracted for. Third is a consistent approach of practice and supervision. We see in looking at across all of the agencies, 80-plus preventive programs, 40 foster care programs, there is a lack of consistency in the services that a parent gets if their child comes into foster care with Children's Aid versus another agency. And we think that there's a real need and a value to making sure that regardless of which foster care agency or preventive program you go to, you're getting the same level of service. And so as a government funder, to have some consistency and know what we're buying is very appealing, and we think will translate into results. The last one, potential for reduced turnover. You all know that the caseworker for families that we are serving is the most important person in this family's life at the government or nonprofit agency, and caseworker turnover numbers are very high, and there's been many studies that show that turnover is highly correlated with negative outcomes. And so there's been some research done that I'm going to talk about a little bit today that shows the use of evidence-based models and how they have reduced turnover in one study, in one program. So I'm going to share a few data slides. This is the outcomes for the Juvenile Justice Initiative. They're a little old, and so we're getting the 2010 data, but when we started the Juvenile Justice Initiative, we had one study that was done, I believe by Bruce Fredericks, and it showed that for youth that were leaving placement, 80% of them were getting rearrested within 3 years. We don't have an apples-to-apples comparison of that here, but we show that for youth that completed JJI, which is FFT or MST or MTFC, the youth that completed treatment in 2009, 61% of them were not rearrested within a year. And we think that's generally good. It's probably better than placement, assuming that these youth were going to placement. It's better if you look, and I didn't want to share this level of detail, but there's pretty wide variance among provider, and that, and if they were maintaining fidelity to the model. So those that maintained fidelity, we had to close a couple of agencies during this time period, and so the numbers dragged down a little bit. But there are some agencies that were much higher than 61%. But the most compelling percentage here is the violent felony arrest, which was only 8%. So even if we think we're providing families and youth with better services here, and the risk of violent felony is relatively low. So this is the repeat maltreatment data. So this is something that we look at regularly as the Division of Child Protection. And what's compelling about this is that 20% of children that have an indicated report have another indicated report within 1 year. And so that's a high number, and we haven't really seen it budge. All of the preventive models that we're looking at in child welfare and juvenile justice, they promise less recidivism. In child welfare, we're looking for reduced repeat maltreatment. And so our hope is to make all of these investments with our provider partners in different types of services that will better suit families' needs and ultimately reduce this churning through the system and give families the help they need the first time or maybe the second time, so they don't come back to us and they don't subsequently lose their children to foster care. So these are foster care outcomes. You can see the median time to adoption and the median time to reunification. Median time to adoption has not really moved, close to over about 52 months, and the time to reunification dropped in 2005 and is currently around 6 months. That is dragged down quite a bit by short stayers that come into foster care. About 15% of children that come into foster care go home within the first 30 days, so that is impacted by that. But we think the big opportunity, we think there's an opportunity to reduce both of these times, mostly the time to adoption, through the Child Success NYC model, engaging parents in a different way on day one, supporting foster parents, reducing caseloads significantly to 12 active children for foster care workers. So this is our reentry. So this has came down a little bit. This is the percentage of children that go home, are reunified, and come back into foster care. So about 10% of children that are reunified will come back into care within a year. Okay, so this is back to the point of how the models are tailored to family needs. And these are kind of the two big points in why these models programmatically are appealing to us as ACS. So the first one is home-based therapy. And the fact that the therapists in these models travel to the parents' homes versus asking parents to keep appointments in a clinic, which is our traditional general preventive model. Often we are reading about and hearing about cases where parents are missing appointments, and it's difficult for a parent to travel to an office with their children sometimes. And so having flexible, portable therapy that will meet the parent where they are, we think is very appealing and contributes to the effectiveness of the evidence-based models. The other point applies to foster care, the foster care model as well, which is the one therapist handles nearly all of the needs through lower caseloads. There are not multiple outside referrals, so there's not a case manager at a general preventive program or even at the foster care agency that is referring the parent to 5 or 6 other programs. So a parenting program, a substance abuse program, mental health treatment. The general idea behind most of the models that we're investing in is that that therapist can do most of those things themselves, and especially on the foster care model. We see all the time that even in the petition for parents, that the parent needs to do anger management and mental health services. The idea is that the therapist, through a lower caseload on the foster care side, can be that one person that's delivering all of those services, so the parent does not have to maintain appointments with 5 different entities and do all of that coordination, which may limit their ability to succeed. So this is, I guess this is really from the ACS perspective as the government agency and doing quality assurance of all of these programs across the city. It's a large number of programs to monitor and ensure that families are getting quality services. So the models provide clear expectations for therapists, supervisors, which ensures that there's an expectation that there's a consistent service that's being provided to each family. And then there's clear accountability standards that are set. A lot of ACS's policies now, if you read them, contain the word should or could, and they're written in a way that many of them are suggestive of a way to work with families. These models are very prescriptive. They have, in the operations manuals, they say must do this, and so from an accountability perspective, it's much easier for us to monitor the types of services that are being provided. The adherence to, so the other big plus here is that there are developers that are associated with the models, which I know many of you know because there is a big FFT program here at Children's Aid. And the developers are very vested in making sure that there is model adherence, that the therapists are working in accordance with the manual. And so the developers are providing coaching and supervision, sometimes through videoed sessions, to ensure that at the therapist level services are being provided, and at the supervisory level the appropriate supervision is being given to the therapists to make sure that there's consistent service provided to all. And there's most of the models develop individual model adherence scores for the therapists, so you can really see if there are certain therapists that need additional support or coaching to really get them in line with the model. So that's really the last point too, that it gives us that having, right now, without having an evidence-based model, ACS, the onus is completely on ACS to do the quality assurance. This gives us another level of quality assurance, and we are and plan to use all of the data that's collected by the model developers in our monitoring and quality assurance. And we can focus less on just making sure that basic casework is getting done, because a lot of our time in agency program assistance and quality assurance is focusing on agencies that are just not doing basic casework. They're not making visits, they're not documenting properly, there's inadequate supervision. And so having a model that that prescribes that, and that the developer is involved in making sure that those basic standards are being adhered to, ACS can more focus its role on looking at outcomes and having those types of conversations with providers. So this is the last thing I wanted to talk about. This is a very interesting study done in Oklahoma around turnover of staff, and Oklahoma was implementing the Safe Care model, which is an evidence-based home parenting skills program, and they implemented it across the state with various providers, and they had 4 different groups that they were comparing, and they wanted to look at the impact of implementation of a model on staff turnover. So the group was the first, and how model fidelity monitoring played into that. And so actually having the program rolled out with support and regular weekly coaching from the developer and model adherence monitoring. So the 4 groups were Safe Care, the agencies that participated in Safe Care with fidelity monitoring, Safe Care without fidelity monitoring, which meant that there was just a training given to the staff and then nothing else. Services as usual with fidelity monitoring, just the services as usual was not a manualized approach, so the coach was really just helping the therapist and the supervisor on basic case issues. And basically giving them support, but not necessarily adhering them to a specific model. And then services as usual with no fidelity monitoring. And what was so interesting, so the researchers thought that the Safe Care with fidelity monitoring would have the highest attrition rate, because they thought that it would take away the autonomy from the therapist, and that it would just feel like a greater burden to be dealing with a consultant and to be dealing with weekly fidelity monitoring. But the study actually showed that the lowest, or the highest probability, they call it the highest probability of persisting with the agency, was with the group that participated in the EBM with fidelity monitoring. And this was, I believe it was a 29-month study, so they're projecting over 36 months based on the data that they had, but that those that you can see, so the probability of persisting with providers in the Safe Care monitoring group was 86%, whereas for Safe Care without the fidelity monitoring was 61%, the lowest, 76% for services as usual with monitoring, and 76% for services as usual without monitoring. So that didn't really make a difference. But the worst outcome, well, at least for the immediate 12 months, was for the group that was asked to do the evidence-based model but was not given the support and the ongoing coaching to actually implement that model with fidelity. So I thought that was really interesting to share, because we are hopeful that this implementation will result in lower staff turnover, but it also really shows how important it is to make sure that the providers that are implementing these models are doing it with fidelity and have the support that they need from ACS and from the model developers to make it a success.
My question just pertains to, would there ever be a thought about ACS getting training in some of the evidence-based models to just kind of complement what we're doing? Because sometimes there's a frustration about trying to present the model in something like an FTC or in a home visit, and really seeing that there's a big gap between what we're doing in practice and ACS's understanding of the implementation. So I'm just wondering, would there ever be a time where there might be some training for ACS staff in some of the models?
Yes, so I'm glad that you raised that. We actually are, we have these implementation task teams that we've launched, because we recognize that this is a huge change for ACS, and there's an entire task team that is dedicated to determining how we're going to train ACS staff, from the conference facilitators to all of the frontline staff in DCP, but really across the whole agency. I think we've identified almost 4,000 people to be trained in the evidence-based models, so yes, that we're definitely doing that.
as I was looking at your slides, I was thinking about general preventive and homemaker service, and how from time to time at Children's Aid we've said we've got to figure out a way to raise some money and do real research to look at outcomes for that. But it is the kind of thing that if some of the major providers in ACS got together, even without a randomized trial or something like that, to do better research on the outcomes that we're getting, might be really informative. Has ACS been thinking about how to research and get more evidence on general preventive model or homemaker models like that?
Yes, so I think, I can't say too much about it because we have an active solicitation, but our thinking is that, and this is why we've left it sort of open in the solicitation to convert general preventive programs, is that we offered for providers to make a proposal to us for a promising practice, which can be something you're already doing. And what we would require, though, is that you have a manual that looks like the manuals for the EBMs, and a guarantee, I guarantee is a strong word, but a commitment from you to actually follow the manual and to determine how you're going to ensure there's model adherence. But we would certainly be interested in looking at proposals like that, and we do have funds that we use. There are analytic and training contracts, and we determine every year how we're going to use those funds, but we're always looking for ideas for research projects. We keep Chapin Hall on retainer, and they do a lot of our evaluation. So we're open to ideas like that.
I think this is clear, but the reason why there's such emphasis on having a manual and having steps is that if you want to replicate, if you want to say that someone is using the model, you have to be able to describe in detail exactly what the recipe for that model is. And so if we just say, oh, we kind of do it like this, that's not enough. And one of the things that we will have to get better as we evaluate all of the work we're doing is being able to spell out. Lachelle's nodding her head. In early childhood, when we do this curriculum, this is exactly how we do it. This is how many sessions. This is how we set it up physically, so that it is replicable and can be evaluated in that way. Next question, please.
Hi, my name is Elizabeth. I work in general preventive, and I had a question with regards to moving from general preventive to doing an evidence-based model without making the changes that you talked about as an ACS standard, because you were saying that with regards to home-based services, you're noticing that there's an improvement when the clients are receiving their services in the home rather than just in the office. But ACS standards right now don't require staff to go to the home more than once a month, and for advocates only once every 3 months. But for our program at Children's Aid, we usually ask staff to go every month to see every family, whether or not it's advocate or CWS based, and they're often doing more than one home visit a month. And then I guess so I'm wondering that we're jumping from standards that ACS has had for years to evidence-based without necessarily seeing whether or not the home-based work itself as a general preventive as a whole would be helpful to families. And then the second part of it is we often do a lot of the work in the home, but with regards to the referrals out, we often are told by CPS if we don't refer out for parenting classes or for whatnot, we're going to take the family to court. So I like that what you're saying is that we want the one provider to be doing the work, but that's not the message we're getting in the day-to-day work that we're doing with families.
That's a really important point, and it's why we really need to make sure that that on the front lines, DCP is connected with this bigger vision, and we're really committed to that. I think I don't want to give the wrong message about general preventive. There's many general preventive programs across the city, and they're very different. But so for now, absolutely, there's lots of good general preventive programs in the city, so I don't want to say that we don't think there's a need for those.
And I would just note that there are a few themes developing this morning. One is, as we move toward more evidence-based practices, that doesn't mean getting rid of everything else we do. A lot of what we do we know is doing good and just hasn't developed the evidence yet. But one thing that using more evidence-based practices does for us is we look at things like, well, if there are better outcomes for some of the evidence-based practices that do more home visits, we can increase our home visits. There are things we learn by just looking at them and improving our practice in other ways. And again, not everything has a lot of evidence behind it when you're looking to achieve a particular goal. In our educational programs, for example, we're going to do a lot of work in after school to mirror what's in the Common Core, because that's the curriculum that's the way that education is moving. There's a lot in the Common Core that is not evidence-based practice, but in order to work well with the schools and what our students are doing in the school day, we need to mirror that. So not everything we do will be based on evidence, but I think looking at it should improve our practice overall.
Hi, I'm Meredith from General Preventive. Just a question, with the jump to evidence-based, somewhat from the outside, I know a little bit about some of the models. It seems like ACS requirements don't always coincide with fidelity to the model, and it makes a lot of extra work. And I'm wondering if ACS is going to start to adapt to make the work more cohesive for the workers and more manageable, as well as, I mean, the whole PAMS monitoring and evaluation system, it was created for general preventive, and it's now being put on the evidence-based models, which doesn't always reflect the work that they're doing. Would be one part of my question. And also, I mean, I'm just wondering, I'm assuming ACS looks at promised data in terms of how many home-based contacts are done from preventive, because I know our program is extremely high. I mean, so just looking at that in terms of general preventive programs, I mean, we're always above 85% home-based contacts for families, so we're not the traditional preventive model. I mean, we think we're a promising practice. I don't think our manual that we have follows the evidence-based manual, so we need to look at that and see if we can adapt it in some way.
So we absolutely need to change the way that we monitor the evidence-based programs. We have another task team that, we have someone from, I forget where she's from, Allison Metz. She's an implementation expert in evidence-based programming, and she's helping us launch all of these task teams to figure out how we can implement these models successfully in New York City. And we have one whole team that's dedicated to figuring out what changes will have to be made in the monitoring and evaluation system and other parts of ACS, but mostly there, so that there are not, because there are inconsistencies with the models and the standards that we're using in monitoring and evaluation. So that work is happening. New York Foundling, another agency, has implemented a lot of evidence-based programs, and they've started to do FFT child welfare using their general preventive contract. And so they have been raising these issues. So luckily, we're a little bit ahead of the curve because we have sort of the most of the issues identified, and so now we're just trying to work through what the solutions would be. But we're looking to sort of reorganize our monitoring staff to be organized around the evidence-based programs, in part because of the issue you raised, but also because there really has to be an expertise built in the model and a relationship with the developers so that they can leverage the data that's produced by the developers and really be an expert in how the model's supposed to work.
Yeah, and to add to that, for when we implement more practices, including being more results-oriented overall, Valerie's working on kind of what is our scheme, what is our plan for having client data collected in a more routine and unified way across the board. As we do that, that's going to be a kind of slow and methodical process, because we don't necessarily want to, if you're already entering into your own client database, to have to do a second set of entries into a Children's Aid database. And so I think as all of us, as ACS, as Children's Aid, implement practices and do more with data, we will do our best to keep in mind how to do that without duplicating your work.